Welcome everyone to IsisParenting's Breastfeeding Chat and Learn. My name is Nancy Holtzman and I'm here at IsisParenting in Needham, Massachusetts. And with me today, moderating in our chat room is Becky Morgan. And Becky is IsisParenting's Pregnancy and Wellness Program Manager here at ISIS. She's a childbirth educator and co-creator of our Mind, Body, Birth by ISIS childbirth class. Becky's also a former doula, a hypnotherapist, who specializes in fertility and childbirth issues, and of course, she is the mom of 3 boys, including twin toddlers. And myself, I'm a registered nurse and a board-certified lactation consultant, board-certified in pediatrics, and I've been working with expecting and new families in the greater Boston area for the past 22 years. And I am mom to 2 teenagers myself, and we're going to get started. So if this is your first time here at our breastfeeding webinar and chat, welcome. As you can see and hear, this is a voice-over slide format, so I do the talking and you guys do the typing. And if you have specific questions for me, please do put them in the Q&A box, because at the end of my presentation, I will go through and answer as many of those questions as I can get through. And today, we're continuing on a topic that we started last week. I called it a baker's dozen reasons for sore nipples. And unfortunately, many breastfeeding women do have intermittent sore nipples or sore nipples at the beginning of breastfeeding, and sometimes the first few days or the first few weeks, and hopefully they resolve quickly and easily, and sometimes they don't. Sometimes sore nipples occur at various times during the first 6 months, 12 months, 18 months of breastfeeding for a variety of different reasons. So I basically sat down with a piece of paper and listed reasons off the top of my head why women can have sore nipples. And of course, I kept coming up with more and more and decided it was just too big a topic to cover in one segment. So I just made my list, and I stopped at 13, so I've been calling it a baker's dozen, 13 reasons for sore nipples, and covering them probably as a 3-part series. So last week, if you were not with us, last week we covered the first 3, which was newness, so simply the first few days of breastfeeding, in particular if it's your first baby and your first breastfeeding experience. Some women do have kind of virgin nipple newness, and we talked a little bit about the reasons for that, the keratin layer of the skin, the breaking of the tiny little strands of connective tissue, chapping and chafing and so on, and ways to manage that. Another very common reason is the baby's latch, whether it's a shallow latch or something that they're doing with their tongue. And then the third reason we spoke about last week is a baby who has a clamping or suck issues, where the tongue doesn't use a nice regular wave the way we like it to, or the baby clamps down and is holding on for dear life with their jaws. And that can certainly make moms sore. So if you missed that and those reasons are important to you, or you have questions about them, then I did put a link right here to view the recording from last week's webinar. And also, every single week we record these, thanks to Becky, who is doing the recording as we speak. And they are archived, and the same link that you took to get here today, you should be able to find the list of the recordings and can go back and listen to anything from introducing solid foods to poop talk, which is one of my favorites, to mastitis or blocked ducts or low supply or oversupply or whatever your concerns are. There's probably already been a webinar on that. So today, I put in red, a good color for sore nipples, what we're going to cover today. We're going to talk about these issues today, and then next week we'll finish up with numbers 9 through 13, and I can't promise that I won't add on a 14th or 15th reason for sore nipples. Okay, so we're coming up to number 4, because we covered reasons 1, 2, 3 at the beginning of last week's webinar. So here are some other reasons why moms may have sore nipples. This reason is related to the baby's oral anatomy. So in particular, there's an issue that maybe 3% of babies may have, and that's called a Tightfrenulum or a tongue tie. And a lot of people look at these pictures of the baby crying and just see a baby crying. But any experienced breastfeeding educator or lactation consultant will look at these pictures and know immediately what the issue is. And if you see the middle picture, even though that's an older child and you can see some teeth there, I included that picture because you can obviously see the frenulum, and that is a thin, fibrous band of tissue that anchors the tongue to the bottom of the mouth. Now, next time you go into the bathroom, stick out your tongue in the mirror and then extend your tongue up towards your nose, and you'll see at the very back of your tongue the little anchor of skin tissue that secures your tongue to the bottom of your mouth. But a baby that has a tight frenulum, that band of tissue actually extends all the way to the tip of the tongue, which it's not supposed to do. And so what that does is it anchors the tongue securely to the bottom of the baby's mouth, and it prevents the baby from sticking out their tongue. So a person, an older child or an adult that has a tight frenulum, cannot stick out their tongue all the way, so it can interfere with things like licking an ice cream cone, licking crumbs off the corners of the lips, other things that we don't need to think too much about in terms of breastfeeding, things like French kissing and stuff like that. But certainly it's a minor anomaly of the anatomy of the tongue, and it certainly can have a very detrimental impact on breastfeeding because it prevents the baby from sticking the tongue out and getting a deep latch. The first picture in the corner of the left-hand side, you see another characteristic of a baby with a tight frenulum, which is not only that they can't extend their tongue much past the bottom lip, but that the tip of the tongue is often pulled in a little bit, and we call that like a heart-shaped tongue. So you can see, instead of the tongue being rounded, there's like a little notch there. And that's another thing that's pretty obvious when there's a tight frenulum. So moms that have a baby with a tight frenulum very often have extremely sore nipples and sometimes some severe nipple damage. Some of the worst nipples I've seen, I call them, they look like hamburger, red and raw and really, really damaged and painful, come from a baby who can't extend their tongue and is simply sucking and chomping on the nipple itself. That's going to make mom sore. Also, the baby can't typically get a deep latch, and so the baby may not be transferring enough milk, and because of that, the mom's milk supply is not being stimulated very well, and she, over time, may decrease her ability to make a full supply of milk. So hopefully, if a baby has a tight frenulum, it's going to be identified early and typically corrected. It's an office procedure unless the frenulum is very deeply involved. It's a little flap of skin that can be snipped in the doctor's office. A general pediatrician probably will not do it, but a pediatric surgeon, a general surgeon, an ENT, which is an ear, nose, and throat doctor, or a dentist. Certain types of dentists actually are familiar with infants and frenulum, and if it can be done within the first week to 2 weeks of the baby's life, that's best because then you can get the breastfeeding well established without much of a delay. If there's a lot of issue with a tight tongue and frenulum, then we got to get mom starting to pump, alternate feed if necessary. Sometimes a nipple shield can be used to protect the nipple until the tongue is dealt with. But this problem is not going to go away on its own. Another reason is oral anatomy issue is a high palate. So again, this is just an anatomical issue where the roof of the baby's mouth has extra space in it. And so even though the baby may be extending their tongue and doing a nice deep latch, there's a lot of extra space in the top of the mouth, and the nipple is getting damaged because of that. And that's, again, something a lactation consultant or a pediatrician may notice. And different types of positioning or temporary use of a nipple shield may be helpful in the short term for that. And then other anatomical issues on the baby side would be a very small mouth or a very tight mouth, certain types of muscle tone, a baby that has a recessed chin or jaw. Sometimes babies just have a small jaw, and sometimes there's syndromes like Pierre-Robin, which is the baby actually has a pretty noticeable indented chin area, and that can make for some careful positioning and extra support on the baby's chin and jaw in order to get a deeper latch to transfer milk better. Other issues I'm not going to get into here, but things like a cleft palate or a cleft lip or a submucosal cleft palate. But those are going to be issues that you're not going to stumble across just because mom has sore nipples. Those are issues, obviously, that you would know about at the time of delivery. Okay, so another reason why moms may have sore nipples is the mother's own about them. So the first one is, I put that in quotations, a normal nipple, whatever the heck that means, because as someone who has seen, I don't know, several thousand nipples in my life, I can't tell you what the heck a normal nipple looks like. I can tell you it doesn't look like a bottle nipple, and it certainly doesn't look like a perky little pencil eraser stuck on a perky little breast. Nipples come in all shapes and sizes, and there's no one ideal or no one normal. But I guess you got to start somewhere when you look at pictures like this. So the first one is what a typical nipple that's at rest, not drawn out significantly, might look like. Now the second picture in is a flat nipple, and a flat nipple is not the same thing as an inverted nipple. It may look the same at rest, but the difference is that when you compress the areola, the nipple may protrude a little bit, or it can be drawn out. An inverted nipple is not going to be drawn out with vacuum. It's actually held in. It's actually got little strands of connective tissue deep within the breast that are holding in or pulling in the nipple itself. So it truly is inverted and not just flat at rest. A flat nipple, although it may create some initial positioning challenges, is certainly not a detriment to breastfeeding. And it may take a little extra learning time for you and or your baby, but there's no reason why a flat nipple should have a negative impact on getting breastfeeding established and a full milk supply and a nice long breastfeeding experience for as long as you and your child would like. Another thing to be aware of is that engorgement can cause a temporary appearance of flat nipples. So when a mom is over full, maybe sort of day 4, day 5, her breasts are very, very large and firm, and my analogy for that is imagine a beach ball, and then you glue an M&M to it, and then you cover the whole thing in olive oil, and try the heck to get nice deep latch onto that. You're going to slip and slide all over the place, and then the baby's gums may finally be able to grab on to the little M&M and hang on for dear life. So they're going to be clamping on and just clamping on the nipple, and that's going to make you sore. So engorgement itself can lead to sore nipples because the baby who previously had been practicing breastfeeding on a softer, more flexible breast tissue and could get a deeper latch and draw the softer tissue deeper into the mouth, all of a sudden is faced with something firm and hard and slippery with a tiny little nub of a nipple sticking out. And so that changes the whole terrain. It makes it more challenging to latch and to breastfeed. And mom is so grateful that the baby is finally latched on and not screaming that she lets the baby stay there and hang on to the nipple. And so ultimately mom is going to get quite sore. So if you truly are engorged and having a hard time latching because of that, it may be beneficial to use some techniques to try to soften the breast a little bit, the areola behind the nipple a little bit, which will help the nipple extend more and allow the baby to get a deeper latch. Now, when the breast is engorged, it's not necessarily packed full of milk. So a lot of engorgement is just swelling. It's extra body fluid, the interstitial fluid that moved from your ankles, perhaps, or your legs up to your breasts. And so even though the breasts are firm and full and hard or heavy, sitting at the pump for 20 minutes may not necessarily yield you ounces of milk. So pumping for long periods of time is not always the best remedy for engorgement. Using ice, ibuprofen, gentle pressure around the areola, maybe manual expression, maybe using a manual pump or a breast pump for just 3 or 5 minutes to help soften and draw the nipple out. That can help the baby latch. I put a link here. You'll see where it says engorgement is a live link, and that goes directly to the webinar recording where we talk specifically about how to manage engorgement. Okay, other reasons why mom's breast anatomy can lead to sore nipples. Some women do have very long nipples. I've seen There's one particular ethnic group who often has nipples that almost can resemble half of a pinky finger on the breast, and very, very long, uh, flexible nipples. And so sometimes, depending on the baby's suck, that can cause some pain. Other women have very large, thick nipples. It could be the diameter of a quarter, or look like a big, thick gumdrop sitting on the breast. And then bifurcated nipples. So not everybody's nipple is exactly cylindrical and symmetric. Some nipples have one side raised a little higher than the other, or it may have like a little bit of a dimple, or another quarter of a nipple kind of growing next to it. And so all of those things can temporarily cause some growing pain. And latched on well, they're not nipple feeding at all. They're breastfeeding. And that's why the size or the shape of the nipple doesn't matter a whole heck of a lot, or the fact that someone has a flat nipple or even an inverted nipple doesn't necessarily interfere with breastfeeding, because the baby should have their mouth open nice and wide and take in a nice mouthful of breast tissue. If they're just sucking on the nipple itself, that's how you're going to get sore. And in last week's presentation, I did a little example of having people suck on their index finger all the way to the first knuckle, and then slide the index finger out a little bit. And that's a good example of what is a deep latch versus a shallow latch. And when the baby is latched shallowly, just like in that example, you can feel that the tip of the nipple is getting rubbed and compressed and a lot of friction, when in fact, when it's positioned properly, it should be all the way toward the back of the baby's mouth, and there shouldn't be pressure or friction or compression on the nipple itself. Okay, and then other reasons why mom's own anatomy can create soreness is the fact that the breast and the nipple and the areola are skin, and some women have skin issues in different portions of their body, and the nipple and the breast is just another area of skin. So if you are someone who is prone to sensitive skin, eczema, dermatitis, irritation, if you have moles all over your body, and you may have moles on your breast or even on your areola, there's a lot of just regular old skin problems that have nothing to do with breastfeeding that can cause breastfeeding challenges, particularly if the skin is starting to get chapped or wet. You know, if you're sitting around in wet bra pads quite a bit of the day, and you are prone to skin irritation, that's going to create irritation. And I'll talk a little bit more about this later on, but also things like if you're using fabric softener in your bra, you know, when you wash your clothes, or certain laundry detergents leaving residue. If you're using certain type of a bra pad that your skin may be allergic or sensitive to. Different types of creams or ointments can cause irritation. So most people are not allergic to the lanolin cream, but it is a wool derivative product. And some women are sensitive to certain creams and ointments that they think are going to be good for their breasts, but in fact aren't. Okay, what the heck is this? Orobubular disproportion. This is a real thing. So in fact, my daughter, who is now 17 and a half, she was a preemie. She was 3.5 pounds when she was born, and one of the reasons why it took 6 weeks before she could breastfeed was because of orobubular disproportion. Her mouth was the size of a Cheerio, my breast was the size of a cantaloupe, and it really took quite a few weeks before she could grow enough to be able to actually get a good deep latch and transfer milk. Now, because she was only 33 weeks when she was born, she was so sleepy, and you know, she was not ready to really breastfeed fully anyway, and I did need to do quite a bit of pumping for the first 2 months and feed her alternately. But orobubular disproportion is a real thing, and that means that the baby's mouth and the mom's breasts or the mom's nipples are not a great fit initially. And sometimes it's just, it takes the tincture of time for those two things to kind of grow into each other. But there are sometimes some reasons why a certain mom's anatomy and a certain baby's oral anatomy are not a great fit initially. But those things usually can get worked out. Okay, another reason why people can have very sore nipples is poor pumping technique or a poor pump. So some of the ways that pumping can create problems when it comes to nipple soreness is if you're using the vacuum strength cranked up way too high. Now remember, when you're adjusting your pump, you want to adjust the vacuum strength until you want to find the maximum vacuum strength that's still physically comfortable. So if you're trying to grit your teeth and curl your toes and tolerate high vacuum because you think it's going to pull more milk out of you, you're really just going to get yourself sore. It's not going to pull more milk out of you, but it may create it may create pain. It may create edema or swelling. It certainly can cause damage to the skin tissue or underneath. And it's not going to help your milk production. So your goal is to gradually increase the vacuum strength just to the point where it's not comfortable, and then back it down slightly. So don't overcrank your vacuum strength. Not all women are the same size, and not all women need the same size flange. If you find that pumping is comfortable and effective, then you can assume that your flange fits you fine. If you find that pumping makes you sore, and it's not because the vacuum is turned up too high, and it's not because you're sitting at the pump for 40 or 50 minutes at a time, then my first suggestion is to ask yourself, do you feel like your nipple and areola are getting friction rubbing against the sides of the flange? If the answer is yes, try using a drop of olive oil and see if that creates a nice lubrication and avoids friction, and sometimes that will help. And if that's not the answer, then by all means I would suggest trying the next size up flange. We find that about 40% of women that are having difficulty or discomfort pumping absolutely need 1 or 2 sizes higher in terms of the flange size. And these flanges, the Medela pumps, the flanges are interchangeable. We have them all here at ISIS. You can come into the center and purchase them or buy them online from our website, and I'm sure that there are other places that you can find them. But the standard size flange is a 24 millimeter diameter. A lot of women do better with a 27. Length of time at the pump. So I would say on average, most women pump for somewhere between 10 to 12 minutes or 12 to 15 minutes. Some outliers may pump for 18 or 22 minutes or so. In general, I would say that pumping for more than 25 to 30 minutes at a sitting is probably pushing it. So I would not encourage somebody to pump for 40 or 50 or 60 minutes. It's better to pump for shorter periods more often than to pump for longer but less often. In terms of the length of time, a good recommendation is to pump for 2 minutes more than most of the milk has been removed. But some women will say that they read somewhere that they should pump until all the milk stops flowing. But a lactating breast is actually like a leaky faucet. There's always another drop and always another drop, because it's not just a container that's full or empty, it's always making milk. And that's exactly why a newborn loves to just hang out at the breast all evening long, suckling and dozing, because there's always a little more. There's always a little more. So if you're pumping until nothing comes out, you might be able to pump forever, but I don't recommend that. So wait until it seems like the milk flow is slowing down, do some massage and compression, maybe play with your cycling speed a little bit, pump for another minute or 2, and then you should be done. But in general, shoot for somewhere around 10 to 15 minutes in that ballpark. If you need more information about pumping technique and tips and storage and feeding the expressed milk and so on, again, I linked to an hour-long webinar that is full of detail on that. So that's a great one for you to watch. Kind of a summary of the Pump Talk class that we teach here at ISIS. And I believe I'm teaching Pump Talk next week in Needham, next Wednesday in Needham. So if you're local to the Boston area and you'd like to attend, that's a 2-hour class on expressing, storing, and feeding pumped milk and returning to work. Okay, another reason why some moms end up with sore nipples, rarely, but occasionally due to teeth. And I put right on there, fear not. I don't want new moms to worry about teeth. I know that we have a couple of people here in the chat room who have older babies with teeth, and I see that we have, I think Kara left, but I have it on authority that her baby just cut a tooth yesterday, one of her twins. The bottom teeth really should not cause a great problem at all with breastfeeding, because the bottom teeth, and typically babies will get one and then two bottom teeth first, followed by the two top teeth. When the baby is latched on and nursing well, their tongue is extended and they're covering the bottom gum and they're covering those teeth, and so they cannot nurse and bite at the same time. Sometimes the top teeth, even though the baby's not biting, when the top teeth come through, sometimes there's a tiny period of time where you feel a little bit of irritation from the top teeth, because when the baby is latched and nursing, the teeth very gently press, not on the nipple, they're not biting you, but it's just, you know, it's just a slightly new sensation. Now, of course, there are times where a baby who is teething inadvertently or playfully bites down, and so to cope with that, some suggestions are watching and paying attention to when your baby is particularly nippy, because typically it's right around when a new tooth is about to erupt. That's when they tend to get nippy. Often it's when they're playing around at the end of feeding, so you can feel comfortable proactively ending a feeding on your own rather than waiting for them to be done. And then if they do bite down, your inclination may be to shriek and pull them away, but instead what you want to try to do is kind of smush their face deeply into the breast tissue so that their nose and mouth is covered up by the breast tissue, and they'll open their mouth to breathe, and then you can carefully take them off without getting hurt. But it's just like setting limits and all of the things that you'll need to teach your baby and your toddler along the way. You know, that they're not allowed to bite. They're not allowed to bite you at the breast, and they're not allowed to bite their friends, and they're not allowed to play with electrical cords and so on. So you can think of this as teaching them table manners. You want to just be firm and clear if they bite down and say no biting, biting hurts. But try not to yell or shriek or be over dramatic, because sometimes babies get startled. You can see those two bottom teeth that came up, and then on the top row you can see the top of the gum. You can see there's two teeth just about to come through there. Okay, and average age for first teeth is about 7 months. Okay, and then I think this is the last reason that we're going to talk about today before I go over and take your questions. Another reason why moms can have sore nipples at any later point, not during infancy, but later on, may be because of acidity in the baby's saliva, and sometimes if the baby is starting to eat solid foods and eating a lot of acidic solid foods, and I put the jar of apricots on there as an example, peaches, apricots, things like that. And for an older baby or a toddler who's eating acidic foods like tomatoes, tomato sauce, oranges and orange juice, those things, if the baby recently ate and then comes to the breast, sometimes moms that have sensitive skin really can get irritation from the changes in the saliva and the acidity of the baby's saliva. So if that's your situation, I would just encourage you, when your baby is finished eating, before they go from eating solid foods to nursing at the breast, offer them a few sips of water, and that will more or less rinse out their mouth. And then if you are still finding that you're sensitive to that, when your baby is finished breastfeeding, I would just maybe rinse your nipples with clear water. And you can use a little bit of lanolin if you think that's helpful afterwards. And then again, it just made me think about other topical things, because this is a topical reason for sore nipples that can cause pain or irritation on the nipples. Earlier I mentioned using different kinds of medicated creams or ointments. You could be sensitive or allergic to some of the ingredients in those. Fabric softeners in your bra or your t-shirt. If you use cotton bra pads. In general, for babies, most babies have some sensitive skin, and if a mom has sensitive skin, I certainly encourage you to use laundry detergent, but then rinse your laundry well, making sure there's no soap suds left in the wash before they go into the dryer, and then avoid using fabric softener, because the way fabric softeners work, it actually puts a coating of fragrance and a chemical softening agent on top of the clothing. That's what makes it feel softer. And some people are certainly babies, but some adults are very sensitive certain chemicals like that. So fabric softeners are probably not a great idea for anyone that's got sensitive skin. And then, of course, to change your bra pads. And if you are managing with sore nipples, you may want to experiment and see what you do better with disposable bra pads or cotton bra pads. A lot of people will assume that cotton bra pads are going to be softer versus the paper, and it's true, they probably are, but if you're a heavy leaker, it may well be that the disposable bra pads keep you drier, because the newer disposable bra pads work very much like the new disposable diapers. They draw or they wick the wetness away, and then they trap it in little gel crystals so that the layer that's up next to the skin feels drier, so you're not up against something wet. So that's just something else to think about. So next week we'll finish up this topic, the baker's dozen of sore nipples, and we'll talk about these reasons here, whether if there's a crack that's taking a long time to heal. Very commonly it's because there's a little superficial infection that's set in, a bacterial infection, and then thrush. A lot of people think that, that the nipple pain, shooting pain, in the breast, or burning pain when the baby nurses or after feeding is always related to thrush or yeast, which is not the case, but we'll talk about when it is related to yeast and how to know and what to do. Clogged nipple pore, which I have to say is so frustrating and probably one of the banes of my existence. I do have a webinar on that topic in particular, but we'll talk about that as an overview. And then Raynaud's, which some people have no idea is related to breastfeeding and nipples, but Raynaud's is a circulatory issue, and certain people that are very sensitive to cold, their fingers, their ears, their toes, their nose responds to cold in certain ways, may find that their nipple also is affected with Raynaud's. And then just vasospasm and other issues. So we'll talk about that next week to finish out that topic. And before I go on to the questions, just reminding you that we need your help to help spread the word about these webinars so that we feel like we can continue doing them on a weekly basis. And add the link to your calendar. It's the same link for next week and the week after and the week after. Please spread the word if you're in any moms groups or any email lists or on Twitter. Please encourage others to come to the webinar and participate. The archives are available. All of these recordings live on that same link website, so you can browse the different topics and listen and watch any of the ones you like. You can tell a friend that there's a good webinar on block ducts or starting solid foods or bottle feeding the breastfed baby and point them in that direction. So we're just trying to get the word out about these offerings. And I'm on Twitter. There's my handle, and IsisParenting is on Twitter as well. And Becky's on Twitter, but she really doesn't tweet that much. But Becky, you can put your handle on there if you want in the chat room, so we'll all follow you. I wish you tweeted more, Becky. Okay, I'm going to change my slide deck here. I hit the wrong button by accident, but let me... There we go. Okay, I'm going to start answering questions while that slide deck comes up. Here's a mom who says, hi, I have a 13-month-old who's been breastfed exclusively since birth. I am working on weaning her off to whole milk. So far, she doesn't love milk, but I have weaned to 2 feedings a day, morning and night. We have tried eliminating the morning the other day. Okay, but I've weaned to 2, okay, so mom's nursing morning and night and giving whole milk, aside from that. We tried eliminating the morning the other day and she was unhappy, so we thought we would try the night, which also made her unhappy, sitting in her crib crying. Since she doesn't accept whole milk at this time during that transition, we had hoped to give her that in the morning and evening instead of nursing. I wondered if you had any advice or suggestions on the transition. Let's see. Trying to scroll down and see the rest of that question. Okay, so the baby's not taking whole milk. I'm curious, what are you feeding when you're not nursing, I guess is what I'm wondering. And sometimes a baby who's transitioning from breast milk to cow's milk, you know, or formula, if the baby is younger and needs to go from breast milk to formula, is not always in love with the new taste. So a couple things you can do, maybe not in your situation, but for people that have younger babies that are needing to move to a combination of breast milk and formula, if the baby is bulking at the formula, what I would recommend is to first try a blend that is, for example, 75% breast milk and 25% other. And then after that goes well for several feedings, I would do a 50-50 blend. So for example, 2 ounces of breast milk, 2 ounces of cow's milk or formula, whichever you're needing to use, and then see how that goes. So that the baby is slowly getting accustomed to the different smell and the different taste without being overwhelmed with the newness of it, because they really do taste and smell completely different. One suggestion I have, and I'm certainly well aware of the recommendation for 1-year-olds to typically transition to whole milk, although you may have heard that in some cases we recommend 2% milk rather than whole milk, and that's because depending on the body mass index of certain babies and sometimes what the parents look like and so on, sometimes using 2% milk is recommended instead of whole milk. I will tell you that using 1% or 2% milk rather than whole milk may help the transition from breast milk to formula, or breast milk to cow's milk. So that's one thing I would try. But I think I would also, in your situation, try a 50-50. So I would maybe use 2 ounces of breast milk and 2 ounces of 2% or 1% cow's milk for a few days and see how that goes, and then go to try the 2% or the 1% straight and see how that does. My other question is she drinking the milk in the bottle or in the cup? Even though a baby may be able to drink water or dilute juice or even milk from a cup, remember that nursing and breastfeeding is more than just a way of getting nutrition. It's nurturing and it's a relationship. And so even though, again, I'm well aware that often a recommendation is to wean away from all bottles around a year, I think it's a very hard transition for a lot of babies, and perhaps perhaps your 13-month-old may do better rather than, and I don't know what you're doing, so I don't know if you're doing this or not, but I think rather than handing them a sippy cup that has 4 ounces of cow's milk in it, if it were a bottle and they were being cuddled or rocked or read to, and the milk was warmed, I think it may be a slower and more suitable transition. Although I agree that for a bottle-fed baby, we should be moving away from bottles between 12 to 18 months altogether. I don't think it's the end of the world if the last milk feeding of the day is a cuddle and a bottle and warm. It's very nurturing. Sucking and suckling is very relaxing for babies and for toddlers, and it meets nurturing needs as well. So just a thought. So again, my recommendations would be to blend breast milk and cow's milk to see if that's more acceptable. Use a bottle rather than a cup if you haven't tried that yet. Warm it if you haven't tried that yet, and try using 1% or 2% rather than whole as a temporary measure. If your baby is a lean, green string bean and you want to use whole milk, you can do that. But once you get her, maybe stage it. The first goal is to get her to accept the bottle that's half and half. The second goal is to get her to accept the bottle that's all cow's milk. The third step is to gradually transition from 1% or 2% to whole milk, if that's what you want to do. So, just take it nice and slow. Okay, second question I have here. Little embarrassing. I've been breastfeeding 4 months. Let's see, when a baby is done at the nipple, how do I know when she is done? I keep offering the breast multiple times even after she takes herself off, but sometimes they will nurse as long as an hour, but the last 20 minutes or so seem much less vigorous. Should I be nursing that long so they get every ounce possible? My daughter is small, so I want her to grow as much as possible. Pediatrician says she's growing well, and there's no specific concern. Okay, so this baby is 4 months old, and I think that one thing you're going to find over the next 2 months is that, in general, many feedings become shorter and more efficient as your baby really warms up to the world and starts developing other hobbies. For the 4 to to 8-week-old or 4 to 10-week-old, pretty much nursing is their life. They just want to be held, walked, moved, and suckled, and it makes them feel safe and secure and happy, and they just have, they don't have a lot of hobbies in their life aside from nursing. But as a baby gets a little bit older, at 4 months, she's going to want to start holding toys and stuffing toys in her mouth. At 5 months, she's going to want to start holding her feet and stuffing her toes in her mouth. At 6 months, she's going to want to try to wiggle and scooch around and play. And so on. So I think you'll find that a lot of the daytime feedings get slower and slower, shorter and shorter, and expect longer feedings before nap and in the evening when the baby is kind of, drowsy and relaxing. In terms of the length of a feeding in general, as you mentioned, she's probably getting much of her milk during the beginning of the feeding, and then the last, those last 10 and 20 minutes are kind of leisurely hanging out. So imagine that you go to a restaurant with your good friend, you're lingering over your coffee and your dessert, and you're having a conversation, and you're enjoying the environment and the company, and that's what she's doing, and there's nothing wrong with that. But it's true that, she's probably already eaten much of her meal. So another good analogy would be my plate of nice, warm, gooey, chewy chocolate chip cookies. If I kept waving it under your nose and encouraging you to take just another piece, you would probably oblige me. So she's in your lap, she's comfortable, she's relaxed, she's drowsy, and you keep offering her the breast. So who is she to say no? And again, I don't think that that's a bad thing, but I also don't think it means that if you've had to pee for the last half hour, or you want to get up and go to the supermarket, just because she's probably willing to hang out for another 10 minutes and nurse on and off, or kind of that fluttery suckle, which is not so much milk transfer as it is what I call comfort sucking. It doesn't mean that you don't need to, that you can't end the feeding yourself. So some babies will fall asleep at the breast or come off the breast when they're done, but most babies don't necessarily do that. The books lead you to believe that a baby who's finished will self-detach, but I think we can ask in our chat room, and most moms will say that their baby rarely self-detaches. Hey, I haven't put up any good pictures. I've just been talking and looking off into the distance. Okay, let's see. We'll take maybe 1 or 2 more questions, and then we'll call it a day. Here's a question from an old friend of mine who says, lately, a few times during feeding, I start hearing a suction noise from my baby. He seems to have a good latch, but starts making this noise. And at other times will squirm and claw at the breast, but doesn't pull away or stop feeding. Any idea why? Yes. Okay. So a lot of people will describe, I think, what you're referring to as a clicking sound. So the baby clicks at the breast. Sometimes, usually a clicking may mean that the baby is losing the latch and then relatching, and it may have to do with when your milk is letting down and flowing quickly, that he's managing the flow. As long as when you hear him make that sound, as long as it's not causing you any discomfort, you don't feel him clamping or pinching you, he can make that sound if he wants to. He may be clicking and losing and relatching, or there may be heavy flow and he may open his mouth for a moment to let the milk drain out or down, or to get a little bit more air. Or it just may be a certain position that he's in where he tends to make more noise eating. Now, some babies are very noisy eaters, and you may not know that. Your baby may or may not be one of those, but when you come to one of our new moms groups or the breastfeeding group, or you're sitting with other moms who are nursing, you'll hear other babies, who make no noise while they feed, while your baby is making all kinds of slurping and gulping noises, or you'll hear another baby from across the room feeding, and you'll be thinking to yourself, oh my goodness, that kid is so loud. So babies just have different feeding styles, but if he's clicking or slurping, as long as it's not causing you discomfort, I would not worry about it. And then the other question you asked about the squirming and clawing and pummeling at the breast is also quite common. That can happen at the beginning of a feeding when they're a little bit impatient and they're waiting for the milk to let down, or that can happen 5 or 10 minutes into feeding, and that's from what's called the gastrocolic reflex. I refer you to the webinar recording that's called Poop Talk, even though it's not directly related to poop. It is related to the digestive system. So you know that your digestive system is one giant interconnected tube starting at your mouth, going down your esophagus to your stomach, and then to the pylorus, and then the small intestine, the large intestine, and then out the other end. And when you begin to swallow and drink, those little waves of peristalsis, inch by inch by inch, wake up the entire GI system. And this is exactly between when their mouth and their stomach receive milk to stimulate the entire GI tract inch by inch and expel contents that are sitting in the large intestine down the other end. So the squirming and the wiggling, and some babies will turn red and cry or act like they're gassy. They're feeling that GI motility, and they probably have some cramps. But there's nothing, there's nothing physically wrong about that. There's nothing really you can do. It doesn't sound like it's a big issue for him because it doesn't interrupt his feeding. He's responding to the sensations of motility, but it doesn't sound like he's very uncomfortable with it. But again, the Poop Talk webinar talks about the gastrocolic reflex in great detail, so that might be interesting for you. Okay, follow-up question from this mom says that she'll try the 1 or 2% and may try the bottle first because you were trying the sippy cup and that wasn't working. Yes, I think that the sippy cup, the other reason I mentioned the bottle over the sippy cup in terms of transitioning to milk is a lot of people will find that the baby will take 1 or 2 ounces in the sippy cup. But if if it's a bedtime bottle and you want her to take 4 or 6 ounces or more, it's very unlikely that a 13-month-old is going to drink that volume from a sippy cup, regardless of what's in it. Okay, and then final question of the day. Hi, I have a 9.5-month-old son. I've been fortunate to give him only breast milk until now and have navigated through some blips here and there, going back to work. Last week we were traveling, and all of a sudden I had a big dip in my supply. At first I thought it was heat and dehydration, stress of travel, lack of sleep, or even because my son didn't have much of an appetite, but then I realized it was more than that. My supply went down about half. It's slowly getting better, but not anywhere near what it was, so I've had to supplement with formula. I've read, where'd that go? Oh. Let's see, sorry, sometimes these questions vanish when I'm trying to read them. Hang in there, I'm trying to see the rest of the question. Oh, that's frustrating. Here we go, that's the way to do it. Nope, that's not a way to do it. I'm so sorry. I read in the, that's as far as I can see. I read in the something. Becky, are you able to access that question for me? I'm not able to see anywhere beyond that question. If you can, play with that. You can stick it in the box up top. Oh, she did it already. She's so good. No, the one from, hi Nancy, I have a 9.5-month-old son. That one. Oh, we're so professional here. Okay, well, first things I would ask in terms of supply would be making sure you haven't started any new medications, any decongestants, maybe hormonal things like particularly birth control pills. Maybe have you just gotten your period back, or are you about to get your period? Sometimes that can cause a temporary dip in supply. I don't think, I doubt pregnancy, but sometimes pregnancy can cause, that's not usually the way women find out they're pregnant, but I suppose it could be. And then I would just focus on the usual things you need to do to increase supply, like nurse more often, pump after nursing. At 9.5 months, maybe you're feeding 3 meals a day. If you're interested in just short-term trying to boost your supply, you could try backing down to feed 2 solid food meals a day and nurse a little bit more often. If your baby is sleeping in long stretches at night, I would encourage you to pump either before you go to sleep, or if your baby does get up in the middle of the night to nurse, make sure he's nursing thoroughly on both breasts at that 3 or 4 a.m. feeding. If not, pump afterwards, because there's something very special about prolactin level surges at 3 and 4 a.m. that really are encouraging milk production. So basically, you want to think about 7 or 8 times in 24 hours, thoroughly stimulating and emptying your breasts, whether preferably by baby, and if not by baby, then by pump. Make sure you're eating and drinking adequately, and as long as there's no new medication, new pregnancy, anything else like that going on, you should see increase in production within a week. That's basically what I can answer. So Becky, thank you. Becky tried to access the rest of that question too, but we could only read the part we could, so I apologize for that. Okay, let's see. Somebody had a question about pump length, how long to pump. I know 2 questions is too much from one person. No, I can take 2 questions from one person, but I don't see the question. Okay, so I think we're going to wrap up for today. What else can I tell you? Becky, do we have any news that we were supposed to talk about today? Anything going on? I know we're just scheduled a couple of webinars for the end of this month and the beginning of next month, but we don't have them available, the big nighttime webinars. We don't have those available to register for just yet, so I'll tell you more about those next week. If you do not get our emails, put your email address in the chat box and tell me the birth date or the due date of your baby, and we'll make sure that you get the week-by-week newsletter. I write that. It comes out every Tuesday morning, and it ties in with the actual week of your pregnancy or the age of your baby. Follow us on Twitter and Facebook at IsisParenting, and follow myself on Twitter. Let's see, I'll go back to the homepage. And again, join us back here next week at 12 noon on Thursday. And as I mentioned last week, in about a month, we're going to be launching a baby webinar, so not just breastfeeding, but baby related on a different day, and then a sleep webinar on a different day with our sleep team. We have a sleep consultant team here who does a great job doing individualized, highly personalized sleep support. And so we'll be covering a variety of infant and toddler sleep concerns during our weekly webinars as well. All right, everybody, have a great week. Happy nurturing, and thanks so much to Becky for being our moderator in the chat room. Bye-bye.